Today I'm going to be talking about obstetric spinal anaesthesia, and I'm going to be having a little bit of a closer look at some of the aspects of a basic or a simple obstetric spinal anaesthetic. Now, most of these points come out of the recently released obstetric anaesthesia guidelines for KwaZulu-Natal. They are the same guidelines as are practiced in many of the provinces in South Africa. And we're going to be going through these updated guidelines today, and in particular on page 8, which I've distributed. And what we've noticed is when we review anesthetic cases that have gone wrong, it's almost invariably the simple things that we've forgotten to do. So I'm going to focus on that today and give you some of the underlying theory as to why these recommendations have been made. And obstetrics makes up more than 95% of district surgical work in South Africa. So we need to make sure that we're doing the basic, simple things as well as we can. This is the page that I'm going to be going through, and I'm going to be pulling out some of the points from that guideline. So women die under spinal anesthetics because we put spinals into inappropriate patients. We don't manage the complications quickly or well enough, and then things can go wrong, like postpartum hemorrhage. So these are part of the steps that I recommend you always take. And the first thing is you prepare as well as you can. Just before you put in the spinal, you think, is this the right anesthetic to the right patient in the right setting? You do the basics right. You expect common complications, which we're going to go through. You really value the recovery period, and you remember that you can always phone for help, and especially when there are little pauses in the perioperative phase. Now, we talked about this last month, so this will just be a quick reminder, but you have to know your theatre. You have to get to know the equipment that's there. You have to make improvements to that theatre, and you need to know where stuff is that you're going to need urgently. So I'm not going to go through that in any depth, but remember that these guidelines do contain an essential equipment list for anesthesia. So have a system that ensures that these things are always in your theatre. Put this list up on the wall and laminate it, but make sure you check for yourself some of the things that you can't make a plan for if they go wrong. And for me, I check that I've got a working ambu bag, check it myself. I do this before every anesthetic. I check that I've got an oxygen backup source, and I check that I've got a working suction. In particular, working suction is just something you can't substitute for if you don't have or it fails. With regards to the drugs, put one of these up. You don't have to remember doses. You can stick this on the wall, and when you need a drug, you can walk over to it and look it up. It's not an exam. You're allowed to cheat. Just put these things on the wall. Remember, for obstetric seizures, there's always a vasopressor drawn up. I prefer phenylephrine myself, but actually the key is that you've got one available and that you use it liberally. So either ephedrine or phenylephrine, if you're in South Africa, one of them must be drawn up for every cesarean section. The incidence of using these vasopressors is about 70%. So it needs to be drawn up in every single Caesar. In addition to knowing your theatre, examine the patient. It sounds stupid, but do you always examine your patient? And I know that I've been guilty of not doing this in the past. I think that if you're going to give an anesthetic, you can at least do the basics. And for me, that means doing some form of an airway evaluation, listening to the heart sounds, and checking an HB, or at least checking for pallor, getting a feel for how much blood the patient has in reserve. And use your monitors. This is, again, something we forget. We put them on, but do we stop and pause and look at the numbers and say, how do these numbers affect what I'm about to do in anesthetics? And these 3 simple steps will save you so much trouble when the trouble comes. So this is from page 8 of these guidelines, and I want you to take note of 3 points in the preparation phase. The first is that you need to look for signs of hypovolemia. So you need to do a fluid status assessment. The second thing is that it advises that you give 500 moles of clear fluid, and it says it's either a preload or a co-load, but that 500 moles is aimed at rehydrating the patient. The big worry is that you don't want to put a spinal anesthetic into a dehydrated or hypovolemic patient, and I'll have more on that later. And the third thing is, notice that in the essential equipment, there's a pillow, and the pillow is an essential piece of equipment that you're going to use to position the patient correctly. and you need access to pillows in obstetric theatres. Think before you put the spinal in. This is just that as you're setting up and you're about to sort of scrub up to do the spinal, just pause and think, am I doing the right thing? What is the indication for the cesarean section? So if you're doing a Caesar for previous Caesar times 4, are you doing it in the right place? Those patients have a very high risk of placenta accretus spectrums. What is the heart rate and blood pressure? I'm going to come back to this again, but just remember, if the heart rate is less than 100 and the blood pressure is fine, you can probably carry on. If it's between 100 and 120, have a think. You must have a theory as to why that heart rate is up, but it might be reasonable to carry on. If it's more than 120, you need to be a senior anaesthetist before you put a spinal in there, and you really need to understand why. And if it's over 140, not even a specialist anaesthetist should put a spinal in. So anything under 120, you can think your way through it. Over that, you probably need to phone someone and ask, and there needs to be an explanation for that heart rate. Listen to your gut. Does the patient look sick or do they look well? And if they look sick, just pause and have a think about what you're doing. Are things likely to go wrong? This is the previous Caesar times 3 or 4. Or the junior surgeon, junior anaesthetist, and maybe previous Caesar times 1, so difficult surgery. Just think, are we doing the right thing? Are there obvious contraindications? That one's fairly obvious. So the things you must always do are actually quite simple. And the first is you must look at the heart rate over the systolic blood pressure. That's called the shock index. If that heart rate is higher than the systolic blood pressure, stop and think. Always check your hemoglobin. It doesn't have to be a full blood count, but you do need a ward hemoglobin in everyone. And my basic rule of thumb is if it's less than 10, then consider getting a full blood count, because that's an anemia. And where there's an anemia, there might also be other parts of the cell lines that are down, like you might have a thrombocytopenia, you might have a very low, very high white cell count. So those patients, I tend to get an FBC. If their ward hemoglobin is above 10, and everything else looks fine, then I'm usually happy to carry on. It also helps you think about whether you need to order blood or send the patient to a center that has blood products available. Examine the patient like we've talked about, and then come up with a fluid strategy. And that fluid strategy needs to be individualized. So we've tried to write guidelines where we give you a fluid strategy that'll work on most patients. But obviously you need to evaluate the patient in front of you. And this means, do you need to preload the patient? Now, preloading doesn't help prevent low blood pressures after spinal, unless your patient was dehydrated, in which case it was a very good idea. So the preloading is the strategy where you give that 500 mils up front. Co-loading is you give the fluid quickly once the spinal's in, and we recommend that in everyone. And then I've just written there reload, because actually sometimes what we're doing there is we're reloading the patient, we're rehydrating the patient. And you should think about your fluid strategy in every single patient, and it should be matching the hydration status. In the patient that is well hydrated, they tend to get about 1 liter of fluid by the time the baby's out, and another liter of fluid by the time the cesarean is over. So 2 liters for the whole operation. Do the basics right. So everyone gets a good intravenous line. As a minimum, that should be an 18 gauge green gelco that is free flowing. I often put 16 gauge, which is a gray gelco, into a routine Caesar, just so that if things do go wrong, I've got a good line. You should actively exclude hypovolemia, like I've talked about. Everyone gets monitors on before the spinal so that you can see what those hemodynamics are like. And remember that how a patient responds to anesthesia is very important information. If you put a spinal in and suddenly the heart rate's 160, that is telling you something. If the blood pressure disappears, it's telling you something. Maybe you got the hydration status wrong. And while you're reacting with fluids and vasopressor, you should also be considering, why is this patient sensitive to anesthesia? So this is the full page of the guideline, and it's really worth reading this whole thing line by line, and seeing if you do everything on it. So we've packed a lot of information into a small space, and it's got all sorts of things in this guideline about what to do if there's a failed spinal or a partial spinal, and that sort of information. And there's some things that are missing, like there's no guidance about phenylephrine infusions, which I'll come to just now. But it's basically because we could only put a certain amount into these guidelines. I want to pick up on a few points. The first is that you have to assess fluid status. You need good IV access, and that you should preload with 500 ml in all patients as a routine. There are some patients who shouldn't get this, such as your preeclamptic patients or your well-hydrated patients, but this is a good rule of thumb for most patients. You should cycle the non-invasive blood pressure every minute for at least 10 minutes until delivery of the fetus, and then after that you can change it to every 2 to 3 minutes. I tend to change to 3 minutes once the oxytocin has gone in. All the mothers should get face mask oxygen 40%. This is a controversial point. Remember that in terms of the pediatricians and what they're doing in centers where there are specialist anaesthetists, is we're not routinely putting oxygen on the mothers. This is because the babies do slightly better if you don't put oxygen on the mom. But it's in our guideline because when things go wrong, the presence of maternal face mask oxygen buys you time to manage the airway. So this is a guideline that's aimed at beginners, and we recommend that mothers get 40% oxygen. The risk to the baby is, we feel, a lesser risk than the risk to the mother when things, if they go wrong, do go wrong. And then there's a pause. You do the surgical safety checklist, pause just before your spinal and think. Think, am I doing the right thing with the right team in the right place to the right patient? Notice the spinal dose has changed from 1.8 ml of hyperbaric 0.5% bupivacaine to 2 ml plus 0.2 of fentanyl. Remember that there's no fixed dose for a spinal. What we are allowing in this guideline is that you can go up to a higher dose, up to that 2 ml. And this was because the 1.8 ml spinal was associated with quite a lot of intraoperative pain in some patients. But obviously the amount of spinal dosing that you use is related to the patient's height primarily. So very short patients, we've even written in there, when they're under 1.5 meters, they might need a much smaller dose, like 1.6 ml plus 0.2 of fentanyl. So all of these things should be individualized, but what we're allowing for is that the standard spinal can be up to 2 ml of hyperbaric bupivacaine. We recommend giving the second half of that liter as a co-load, 500 ml, so you run that in as fast as you can once your spinal's in, and that should finish just as the baby's coming out, and then the next liter can have a bit of oxytocin and is run as an infusion. Remember that you wedge all patients. You put a right hip wedge, it's supposed to be at 15 degrees, and then the pillow, which I'm going to come to, pillow under the shoulders and the neck slightly flexed. Remember that wedge, it's very important to put it in. I know it's also a controversial area, but we still are recommending it strongly. If your surgeon feels that they can't operate with the patient in that tilted position, leave the wedge in, clean and drape, and then as the surgeon is cutting, you can straighten the bed by turning the bed, because that period from incision to delivery of the baby tends to be just a couple of minutes, but that period from having inserted the spinal to the start of the incision is 15 to 20 minutes. So at least leave the wedge in for that period, and then if you need to straighten the bed, that's acceptable. And just remember to check your blocks before you start. Check them appropriately, document that you've checked them both with sensation and with the patient's inability to move the legs, and document the level. It's very important, especially if the patient suffers from pain. I'm not going to go into too much detail more than that. I want to bring up a few points related to complications we've been seeing around spinal anesthesia. The first is the tranexamic acid, which is recommended by the WHO for all patients who have postpartum hemorrhage. The AMP looks like bupivacaine. Don't confuse them. Don't store them near each other. In fact, we recommend you store your tranexamic acid just outside the theatre so that you can get it quickly, within a minute if you need it, but that it doesn't get mixed up in the same container. And the issue is that there have been tranexamic acid injections into the spinal space, mistaking it for bupivacaine, and intrathecal tranexamic acid is a lethal complication. So please, if you find your tranexamic acid in theatre, make sure it's stored separately in a container, ideally outside the theatre. Now, positioning is so important. It really links to high spinal. So first of all, stick a pillow in and check that the patient has flexed the neck, and then walk to the side of the bed and look at the patient's side on and check that the spine is level with the shoulders slightly flexed, not head down like this patient in this picture. This is obviously exaggerated, but sometimes people have done things to the bed and you haven't realized it. So you need to go and check. You must then straighten the patient so that the spinal level is flat. Now, where this might be a problem is if the patient has steatopygia, the buttocks have this sort of shape, then you have a bed that is represented by that black line. The spinal column is actually in a head down position because of the steatopygia. And so if you give a spinal, it's going to go in the direction of that arrow. And so when you come and you look from the side of the bed, you need to make sure that the patient's spine is level. So you actually end up putting the bed head up so that the spine is level. And this, we think, might be a cause of high spinals just because of the patient's body habitus. Expect common complications. Hypotension is going to happen. Half the patients will drop their systolic blood pressure below 100. A third below 90, and 20% below 80 millimeters of mercury. So 20% will have severe spinal hypotension. And that's a lot. And when I was a junior anaesthetist, I used to have a kidney dish with all my spinal anesthetics because I knew the patients were going to vomit. And so I would keep a kidney dish there so that I was a caring anaesthetist. But what I should have done was given vasopressor, because if you treat the blood pressure well, only 1 in 25 patients will have hypotension. So eliminating nausea in patients should be the goal. You should treat hypotension so aggressively that they don't have nausea. That should be the aim. And just to back that up, we're not losing mothers to too much ephedrine or too much phenylephrine. We're losing mothers because it's not given enough. So you have to be aggressive, you should be on your toes, and you should act early. If the blood pressure cuff is just cycling, give the vasopressor. The cause of the hypotension is pharmacological vasodilation. So you should treat that with pharmacological vasoconstriction and fluids, and then consider the cause. So you should give the vasopressor if the blood pressure drops below 90% of the baseline systolic blood pressure. And that's the blood pressure that you took in theatre just before the patient got their spinal anesthetic, which is higher than the one you've seen in the ward. So aggressively treat the blood pressor. You should give a vasopressor if the heart rate goes up more than 20% of the baseline. If the patient's nauseous or vomiting, give the vasopressor. If the patient becomes confused or drowsy, give the vasopressor. And if you're not sure, thinking, I'm on the fence, give the vasopressor. Very low threshold for vasopressors. Now, hypotension, and that severe hypotension, doesn't always equal high spinal. I recommend you read this article, which is how to manage a high spinal anesthesia in South Africa, and it gives you a little table on how to differentiate. Remember that hypotension and bradycardia, that's where you should start thinking. But while that heart rate's high, just manage the blood pressure aggressively early, low threshold for treatment. This is another article worth reading. It's called the International Consensus Statement. It was published in Anesthesia in 2018. It's a panel of world experts, including South African ones. And this guideline recommends that you run a prophylactic phenylephrine infusion on all your patients at 25 to 50 micrograms per minute. So on this channel, you'll find a phenylephrine dilution short, which will tell you how to mix it. You just put 10 milligrams in 1 ml. And then that'll give you a 50 mic per ml solution. And the titrated phenylephrine infusion is basically 30 to 60 ml per hour on a syringe driver. And you start that once you put the spinal in, and then you titrate after 2 minutes. Or you can use a fixed low dose infusion, which means you just run it at 30 ml an hour and then you bolus on top of that if you need it. Or you can run a phenyl in the bag, which is 500 micrograms into 1 liter. And you run that over 10 to 20 minutes, it's the same as 25 to 50 mics per minute. So you get a full liter, and you run that once the spinal goes in over 10 to 20 minutes with 500 mics of phenylephrine in the bag. There's also a short on how to draw that up. And that recipe is in that consensus guideline. So it's worth a read to see how to do that. And then value the recovery period. This is so important. So many patients get through the operation, but in recovery, there are signs that things are not right, and they signed out prematurely. So really use this recovery period. And if you have that feeling in your gut that you're signing out a borderline patient, make sure you visit that patient in the ward within an hour or two. So these are the things that are in the guideline. One of them is that we should put oxygen on with a 40% Venturi mask on all our patients. My belief is that that is correct following a general anesthetic, but after a spinal anesthetic, I don't routinely use oxygen in recovery. If you need oxygen, you need to ask yourself why. Monitor the patient well, look at the NIBP and the heart rate, and when the heart rate's above the systolic blood pressure, think about what the causes, and make sure that the patient's not bleeding, well analgesied, there's a spelling error there, and infuse 20 units of oxytocin and 1 liter of clear fluid over 8 hours. And remember that at this period, even if something's worrying you, you can phone for help. You can phone your referral center or a senior doctor in your hospital and just say, I'm not happy. So many patients that bleed post-operatively are already presenting in recovery and they're missed. That's all. Please get hold of the guideline, read it through carefully, and get hold of me if there are any questions. Thank you.